The topic is schizophrenia. Schizophrenia is a complex psychiatric disorder in which the client is unable to interpret and interact with reality normally. Causes for schizophrenia are not completely understood. It is believed that it is a combination of genetics, the environment, and then brain chemistry. The neurotransmitter dopamine has been seen to play a large part in schizophrenia. Too much dopamine in the limbic part of the brain causes positive symptoms. Too little dopamine in the prefrontal cortex causes negative symptoms. What does the client with schizophrenia look like? Here are some clinical manifestations. The positive or psychotic symptoms, I don't want you to think positive as good or bad. I want you to think of positive as added to. Remember, these clients are the ones that have an excess of dopamine, so too much and it adds to. We'll go through these more later, but they include hallucinations, delusions, disorganized thought or incoherent speech, and then disorganized or agitated behavior. Now let's talk about the negative symptoms. Again, negative doesn't mean bad. It means lack of or something is missing, taken away. Remember, this is when the client is experiencing a dopamine deficit. So low dopamine means negative symptoms. To help you remember these, you can see they all start with A. Apathy, lack of interest in the environment and lack of interest in things that used to bring them joy. They may have poor hygiene, poor eating, sleeping, and elimination, and self-care. Abolition, lack of motivation. These clients have difficulty starting things and then following through to finish them. Asociality. This is being socially withdrawn. It's an avoidance of relationships, and this may be done due to depression or feelings of safety when they're alone. Affective flattening. This could be emotional flattening or speaking in a monotone speech. Anhidonia. The inability to experience pleasure. And then aloia, poverty or lack of speech. Let's talk about hallucinations. Hallucinations are based on senses. This is important to remember to understand the difference between hallucinations and delusions. Hallucinations are false sensory perceptions in the absence of stimuli. They come in the forms of auditory hallucinations. The client may hear voices or noises. They might have visual hallucinations where they're seeing things or even people that aren't there. Tactile hallucinations, they're feeling bodily sensations like spiders crawling underneath their skin. And olfactory hallucinations, they might smell something that's not there, like a burning fire or something burning. Delusions, these are based on beliefs and ideas. Again, it's important to understand that it's beliefs and ideas that makes it different from hallucinations. Here's a list of delusions. Paranoid delusions, or feelings of being persecuted. Grandiose delusions. Delusions of reference, and then delusions of control. You can see in the illustration an example of a delusion. In the first illustration, the client has an individual thought. The delusion is shown in the second illustration. The client thinks that his thought is being broadcast and is being able to be heard by others. And then in the third illustration, you can see, in reality, others truly can't hear his private thoughts. Continuing with the positive clinical manifestations. Disorganized thought or incoherent speech. There are different examples of this. Loose associations, derailment, no logical flow. The stars are twinkling in the sky. I like my blanket. Oh, did you hear about my blanket? Would be an example. Neologisms. These are new made-up words. Instead of saying I walked outside, I walked jibber-jabber into the fluky-walkie. Tangentiality. This diverges from the main topic. Word salad is jumbling with no meaning. There's no thought process or linking from beginning to end in this. Echolalia. The client will repeat phrases or words. They might just be able to say one thing. 5, 5, and that's their answer to every question you ask them. Disorganized and agitated behavior. Catatonia. This is when the client becomes immobile, or they go into peculiar postures, or they're unresponsive. They also might have psychomotor, slowing, or agitation. Treatment for schizophrenia includes prescribed medications. The clients will be prescribed antipsychotics. The first generation, or typical antipsychotics, do a really good job managing these clients, but they have adverse side effects. And those side effects are normally bodily side effects or movement side effects. Then, second generation, or atypical antipsychotics were developed. These can also be used for clients. Their side effects tend to be weight gain. Antipsychotics mainly help with positive psychotic symptoms because they act on dopamine. So those clients who have excess dopamine causing those positive symptoms, the antipsychotics work on that dopamine and bring them back to middle. Long-acting injectables improve adherence and outcomes. It's much easier to have an injection and have that last for a period of time versus taking medications every single day. Nursing interventions for the client with schizophrenia in general include building client trust. We want to establish a trusting, therapeutic nurse-client relationship. This is done by being honest and consistent in our interactions. And then having frequent and short interactions. We don't want to overwhelm this client. We might even just have to sit calmly in the client's room. Sometimes our presence is enough. We want to avoid touching the client without informing them first. This allows the client some form of control and also allows them to set boundaries. We want to maintain a balanced, neutral approach. We don't want to be overly warm. We also want to explain procedures step by step. It's much easier for a client to understand things in small bits of information. And we want to initiate activities on a one-on-one basis first. Allow that client to work with you one-on-one and then eventually introduce them into small groups. Nursing interventions for clients experiencing hallucinations include monitoring cues. What might be setting them off? When they walk into the break room, that's when they have a hallucination. And asking the client directly about the content of the hallucination. What are you hearing? What are you seeing? We want to monitor for worsening anxiety or agitation. This might indicate that the hallucination is escalating, and that could also escalate the client. We want to decrease stimuli or assist the client to another area. Decreasing that stimuli might be removing that client to a quieter area. We want to provide distraction. Music with headphones is a great idea, especially if that client is experiencing auditory hallucinations. We want to explain verbally what is real and what is unreal without a judgmental tone. We want to engage the client's attention through structured, small activities. If we can give them small activities to concentrate on, maybe we can ward off those hallucinations. And then we always want to make sure and check for suicidal or homicidal ideation due to command hallucinations. This is a very dangerous complication for the client with schizophrenia. We want to make sure that they are not having suicidal or homicidal ideas. Nursing interventions for the client who's experiencing delusions. We want to provide care with active listening and empathy. Again, we want to establish that trusting, therapeutic nurse-client relationship. We don't want to argue with them or try to convince the client that the delusions are false. That's not what we're here for. We also want to shift conversation on reality-based topics rather than on the delusion. If the client is afraid or thinks they are in danger, we want to use canned or prepackaged foods. Also, we can open medication in front of the client, so then they can't think that it's something that is unsafe for them. We want to check their mouth and palms after medication administration to ensure that they're taking the medication. And then we want to provide positive reinforcement. Anything that they are moving forward on, we want to encourage. Nursing interventions for the negative symptoms include social skills training. We can model these skills, and we can also show them examples of this. It's easier for a client to understand what is expected of them if they can see it. We can also measure client readiness to engage with others. Again, we don't want to put them in a situation where it's too much too soon. And of course, we want to praise progress towards increased interaction. Any step forward should be encouraged. Then we want to assist the client with activities of daily living. The nurse can break down these activities in step-by-step small steps. This gives the client a sense of accomplishment if they've done one small step. Then they can do the next, and the next, and the next. For the client in a catatonic state, fluid and nutrition is a priority. They might be unresponsive. They might not even understand that they're hungry and thirsty. We want to make sure that we are thinking of this and we are addressing this for this client.